Good evening, everyone. It's a great pleasure for me to be at today's webinar by the CCI. Today is a very interesting topic called Basics of Clinical Diagnosis. At the outset, I'd like to thank CCI for giving us an opportunity to have this Basics of Clinical Medicine. Today, I am the moderator. Myself, Dr. Sushil Jain. I am from Raipur. I'm the head of the Department of Pulmonology at Ramakrishna Hospital, Raipur. We have eminent panelists from across India. Dr. Radha Munje from Nagpur. Dr. Ashish Jain from Delhi. Dr. Mahesh Jansari from Jansari from Kalyani. Dr. Nupur Kulkarni from Goa, and Dr. from Thiruvalla. So today, the flow of the webinar will be like this. I'll be giving a short introduction. This will be followed by back-to-back two video presentations, two PPT presentation. First by Dr. Ashish Jain on history taking, and the second video presentation will be by Dr. Nupur Kulkarni on clinical examination. This will be followed by a live discussion with the panelists on today's topic. Can I talk audio visual team? Is there some sound going at the background? Can someone stop it? Excuse me, audio visual team. Now it is better. So there was some sound going on at the background. That's why I said stop it. So now, we'll start today's presentation. A small introduction of today's topic. Basically, today we are going back to our clinical medicine, which we have learned over the years, but we have forgotten a part of it, and gradually we are shifting from clinical medicine to investigational medicine. We are now more and more dependent on investigation, and we are going less and less on clinical work. Probably one of the reasons being that we don't have a lot of time to spare to give a patient and do a detailed history and clinical examination, and that compromises our clinical decision making. So we are trying to get back to our clinical medicine, get back to our root, and revise what we have learned over the period of time in the last 20-25 years, and then we discuss it with all the panelists at how we can improvise our clinical work, which we are doing today, and try to reduce the burden of cost on the patient, also reduce the number of investigations, which can have its own complications if we do it without a judicious reason for it. So that's the purpose of today's webinar. Just describing how we'll be discussing it. The clinical medicine is basically two parts: history taking and physical examination. And I think that's what we will be focusing on. We will not be discussing investigations in today's webinar. That's for sure. We will avoid discussing any investigation part in today's webinar. It will be purely clinical. Then, as far as the history taking is concerned, we'll discuss about chief complaints, history of present illness, past history, personal history, occupational history, family history, drug history, and social history. We may not be able to talk about each of them, but at least we'll try to take some important points out of this history taking. And after the history taking discussion, we'll be discussing, and also during that period, that we'll also be discussing about common respiratory symptoms like cough, sputum production, breathlessness, hemoptysis, and other constitutional symptoms like fever along with it. Once we have discussed the history taking, we'll go to the physical examination part of it, in which we'll be discussing the general examination and the systemic examination, including inspection, palpation, percussion, and auscultation. We may not be going exactly in the flow which I'm mentioning here, which will try to be more and more practical and more clinical, and the common information the important points we need to, the message we want to give to the audience, we'll try to focus on them. So, from here onwards, I think I stop my introduction, and I request my audio visual team to please start the video presentation. We'll have two back-to-back video presentations, and following that, we'll be having our panel discussion. Thank you.
Hello friends, I am Dr. Ashish Jain. I head the department in Max Smart Super Speciality, Saket, New Delhi. And first of all, let me thank the CCI for inviting me for such a fantastic topic, a topic so dear to me, that is about the history taking. I've been asked to take a talk on history taking tips and tricks. Now I have reshuffled it a little bit. I have made it tips and tricks. The context is history taking. So there will be plenty of tips and tricks in my talk tonight. Now let's go back to the basics. And this is the structure which I have displayed on the screen. This is the structure of history taking, and I know that we are not taking a lecture on the for the undergraduates, so there is no point for going into detail, but I'll share some anecdotes and give you some tips and tricks about the structure. The first and foremost is the presenting complaints, and the most important question that you need to answer, or that the answer that you are seeking to the most important question is, why is the patient here? Why are you here today? This is the most important thing, and what bothers the patient most is what you would like to know, because everything revolves around that. Has the patient detected some problem today, or was the patient having some problem, for example cough, for last 1 week, and suddenly started having hemoptysis today? So why is the patient here is the question that you are going to ask your patient every time during your consultation, whether in the wards or in the OPD. Second is the history of presenting complaint. Go back into the time with the same symptoms or same cluster of symptoms and ask about how it all started. There's very important phrase in our history taking which we learned in third year while taking the clinical classes, was the patient was apparently all right till so many days ago. Probably it did not make sense in the third year MBBS, but now it makes perfectly sense, because you would like to know that what was, how many days ago the patient was all right, right? Also, do not forget to ask the functional status of the patient before all this developed. You must know whether the patient was bed bound, wheelchair bound, walking, climbing upstairs. What was the patient doing before the problem started, right? And you'll ask some open-ended questions like, is there any other problem or any other issue that the patient may want to discuss, or move to closed-ended questions. Then comes the past medical history. You would like to know whether the patient is having any other comorbid illness like diabetes, blood pressure, and you must ask, instead of asking, do you have diabetes or blood pressure, the tip is that one should start asking, do you take any medication for diabetes or blood pressure? More often than not, the patient will come out with some answer. The human body is very well organized and interlinked. All these structures are interlinked. So you must, it's not like a car you're taking to a service station and asking to change the carburetor or some AC filter cleaning. So one organ will definitely affect the other organ. Not only you must know about all these things, but you must interact with the patient in such a fashion that you can elicit all these problems. For example, you will miss the Wegener's granulomatosis if you don't ask about blood in urine. You will miss the sarcoidosis if you don't ask about the skin lesion. The patient may feel that they have come to a respiratory physician. Why should they talk about this? So all these things. A family history is very important. About all these genetic and the inheritance illnesses which you must ask. About the drug history, please make sure that you ask the patient to bring the prescriptions so that they can show you the list of the medications they are on. The social history is important for the young adults if they are there, or if the husband is there with wife. You know, they may not be very comfortable in sharing the history of smoking, alcohol, or other things. Um, when they are with their parent or spouse, but make sure that you make them comfortable, ask them in person about this, especially about the hookah thing. Hookah is so widely accepted amongst the young kids and the family and the society that they think that this is okay. I mean, why should they even bother to talk about this to the doctor? Now, this is very important. I'm going a little fast, but this is very important. You are hearing the patient, but are you listening to the patient? You know, stay away from distraction. Don't take your phones. Don't look here and there. Don't write the notes. You have to listen to the patient. The patient has come all the way to tell you their story, and you have to give them a good listening. Those who don't learn from the history are doomed. Well, in medical profession, the phrase ends right here. Um, this is so important to understand the importance of the history taking for a doctor, so that we can reach to some sort of a diagnosis. The artificial intelligence breeds natural stupidity. We are seeing the AI taking over all the radiology, all the labs. The automation has taken place, but you must remember that you are already born with a pre-installed app in you. You know, and that's the brain. Please use it, right? The AI can take over everything. But it cannot master the human touch, the empathy, the concern, the confidence, the patient, and the gut feeling of the doctor. And that is so unique to humans. And so let us try to be human while dealing with the patient, rather than relying all the way to the AI. So, what is the take home message? The take home message is history taking is the most important step for making a diagnosis. This is the take home message. And but when you start mastering the history taking, when you start mastering talking to the patient, listening to the patient, your gut feeling, your instinct, it becomes very important. And every time you think that this can be the problem, or this can be the diagnosis, or why cannot this be a diagnosis, more often than not, you will start with experience, start clinching the diagnosis. And the other thing is that talk to the fellow colleagues, discuss among yourself over the coffee breaks, in the corridors. Talk to your senior, talk to your junior, attend the webinars, what we are doing right now. Attend these webinars, and that will sharpen your skill, that will improve your clinical acumen for better history taking. And with this, thank you very much.
Good evening, everyone. At the outset, I would like to thank CCI for providing this wonderful opportunity and platform, and a chance for us to go back in time when medicine was a simpler issue. Now, we have already seen what are the tips to keep in mind while taking a detailed history from a patient. Let's go into clinical examination signs and techniques which may help us to diagnose a patient before we perform complex investigations on them. So, a 60-year-old male smoker who is probably a case of COPD comes to you with massive hemoptysis, and he's also complaining that for the last 3 months he has been unwell with increasing dyspnea, cough, and a significant weight loss. So, this patient may be having an underlying malignancy. Are there any markers which may point towards this? So the presence of clubbing in COPD is very alarming and must be evaluated. Cervical lymphadenopathy, anemia, these are the soft markers which may point towards malignancy in this patient. Other signs like a presence of a mass with an underlying collapse, which may be evidenced by presence of trail sign, decreased spinocerebellar distance on the affected side, shoulder drooping, and crowding of rib spaces. A 45-year-old uncontrolled diabetic comes to you with cough, fever with chills, breathlessness, and right-sided chest pain. So what are the signs which may lead you to a diagnosis? So any patient coming to you with this kind of a clinical picture, we may think of an underlying pneumonia or pleural effusion or empyema. So presence of diminished mobility on the affected side of the chest, bulging intercostal spaces with an overlying skin which is red and shiny, tenderness, which is localized tenderness, absent tactile vocal fremitus, and a stony dull note on percussion are all pointers towards empyema. So such patients on auscultation will probably have absent breath sounds, and patients with a pleural effusion, we may also perform shifting dullness in them. So this picture is a classical picture of a patient with empyema necessitans. A patient in ICU on invasive mechanical ventilation was improving and now suddenly has become tachypneic, and monitors are blaring and they are showing that there is an increase in the peak pressure and the patient is desaturating in front of you. So you will probably have 2 or 3 differentials in your mind, which include a pneumothorax or a pneumomediastinum. Patient may have an acute coronary event, or patient may have pulmonary embolism. So how do you come to a diagnosis bedside before doing an X-ray or an ultrasound? So a simple procedure, which is percussion. So you percuss the patient, and on the affected side, you will find a hyperresonant note in case of a pneumothorax. In such patients, we also need to keep in mind to check for mediastinal crunch or Hamann sign. That is a sign of subcutaneous emphysema, which may happen in patients who are intubated for a long time and present with breathlessness and increase in peak pressures. A 20-year-old male coming to you with dry cough, and he also tells you that he has noticed neck swellings over the last 1 month, and he's feeling unwell since the last 2 weeks, having anorexia and a significant weight loss. Now, in a young patient, we may have many differential diagnoses ranging from an infection to malignancy. But what are certain physical markers which may help to suggest the diagnosis? So this patient was actually having a testicular mass. So I had put this slide actually just to reiterate that in our routine OPD practice, we see a lot of patients, but we forget to examine the scrotum and the prostate in males and the breast examination in females. So this actually must be incorporated in our routine clinical examination of all our patients. A 50-year-old male comes to you with fever with chills, right abdominal pain, and dry cough since a week. Again, this patient may be having an underlying consolidation, or may be having something in the abdomen, may be having a pleural effusion or an empyema. So what is that one particular sign which you will demonstrate to come closer to a diagnosis? Apart from your routine examination of the respiratory system, per abdominal examination, a sign which will help you is the tidal percussion. This sign is basically a sign which is done during routine palpation, and it helps you to differentiate between supradiaphragmatic and infradiaphragmatic pathologies. A patient of pleural effusion has come to you with dyspnea, and you have done a therapeutic thoracocentesis in him. He is very happy now because he is comfortable. However, after 2 hours, he comes again to you with dyspnea. So now you know that temporarily, since you have already tapped him and he has come back to you with dyspnea, you are thinking of a iatrogenic hydropneumothorax in him. So are there any signs to help elicit a diagnosis in this patient? So 2 important signs, that is a succussion splash and the coin test, will actually help you to diagnose hydropneumothorax bedside in this patient. The next case is that of a 63-year-old female who has uncontrolled diabetes, and on examination you notice that she has a very badly infected wound over the dorsum of her left foot, and she tells you that she is breathless since this morning. When you evaluate her, you see that her SpO2 is normal. On auscultation, you don't find any evidence of consolidation or a pneumothorax. So now you start to wonder whether this breathlessness could be extrapulmonary. So is there anything which will give you a clue? So in such patients, you need to note also the pattern of breathing. So this patient had acidotic or Kussmaul's breathing. So Kussmaul's breathing is nothing but an increase in the rate and depth of respiration, which happens in various conditions like diabetic ketoacidosis, sepsis, lactic acidosis, methanol poisoning, etc. A patient of COPD comes to you with a slight increase in respiratory distress over the last 2 days. However, other markers such as pedal edema or an abdominal fullness, oliguria are absent. You try to elicit for any cardiac history, that also is not there, and patient also clinically has no evidence of a pneumothorax. So, is there any sign which appears in such patients before the appearance of classical symptoms of CCF? Yes, and that is the hepatojugular reflux. So basically, hepatojugular reflux is when you apply a pressure over the right upper abdomen, there is a sustained elevation in the JVP of such patients. This happens because a failing right ventricle cannot compensate for the increased preload which happens during this maneuver. So I would like to end my presentation by saying that in today's era of modern medicine and precision and evidence-based medicine, it is important to evaluate and investigate the patient. But at the same time, we must not forget that a detailed history and a thorough clinical examination are very, very important, and they form the foundation of our medical practice. When you apply these two together and you critically analyze both of them together, that is the history and clinical examination, it may give you a differential diagnosis to a fair certainty. It also helps to foster a bond between the doctor and the patient as well as the patient's family. And we may also help the patient by cutting down on unnecessary investigations. Of course, modern medical technology is important, but we must never downplay the importance of a good history taking and a thorough clinical examination. Thank you.
Yeah, good evening, everyone. That were wonderful presentations by two of our colleagues, Dr. Ashish Jain and Dr. Nupur. Now we are going live to discuss this topic with our panelists. We'll be having question answer sessions, and we'll try to incorporate all important points in history taking and clinical examination of a patient with respiratory diseases. Now, the first question I want to ask Dr. Ashish, can you please elaborate on to how to take a good history of present illness? Because I think that's a very important part of history taking. And because your initial presentation was on history taking, I think I would request you to give a better insight on how to take good quality history of present illness.
Yeah, thank you very much for inviting me in this webinar. This, as I said in my presentation also, this is a topic which is very dear to me. And this history of present illness is so important. I mean, the patient has come to you to talk to you about and to get some relief from his present illness. So this is what you're supposed to do. Now, some basic things are there, and most of us are already doing this, but just to complete the checkbox, let me tell you, first of all, you have to be presentable. Even in these today's day and age, when you are on a video consultation, or you are in the clinic, or you are in the ward, it is very important that you be presentable and you be approachable. The patient should be able to talk to you, the patient should be able to discuss with you. And most important thing is that, he is confiding in you his secrets about his illness. So you should be receptive to that patient. And then there are basic bedside manners that, first of all, you have to introduce yourself to the patient. The patient will come and, and ask him whether he can, whether you can take the patient's, whether he's ready to take your questions rather, right? So this is the preamble. Now coming to the history of the present illness, the most important thing is what brings the patient here? Why is the patient here today? Right? So you'll try and ask the patient that, okay, fine, tell me, why are you here? Here, in the tips and tricks session, most of us have already done our undergrads and postgrads, and we know basics of the history taking. But there are certain tips and tricks. What patient feels important may not be so important in making the diagnosis, or it may not be important to you, but that is the patient's story. So please hear him out. That is one. And number two, we should be smart enough to separate the wheat from the chaff, right? For example, there are patients, those who come with cough syncope. Now they are more concerned about their syncopal attack rather than their cough. They are probably not so much interested in talking about their cough because they have been coughing for weeks together. Let me share with you one anecdote. I was doing my MD in Ahmedabad, and there was a boy was wheeled in on the stretcher, and the mother was accompanying. They were probably some slum dwellers. And when the boy did not respond to our questions, obviously he was comatose or he was very drowsy. But when you asked the mother, she said that, he's just not eating for 2 days. So I said, what is the problem? What happened? I don't know. He's just not eating. So she was more concerned that the boy is not eating while the boy was comatose because he had tubercular meningitis, right? So what bothers the patient may not help you in clinching the diagnosis. So it is, but you have to hear the patient out. Once you have heard the patient that, okay, fine, he'll start that, he was standing and then suddenly he fell down, and then his wife came and then his son came and then they pulled him up and then they slapped him and then threw water on him. And then after 5 minutes, he regained the consciousness. But this is not the problem. The problem is the underlying cough. And I want to know more about the cough, right? So we have to be able to distinguish between what the patient's concern are and what our concern are when we are making the diagnosis. So we have to lead the patient towards those questions. So these are few tricks about taking the present illness, and then you go on the structured way. You ask for the social history, you ask for the family history, you ask for the drug history. One thing very important now, although we are not discussing about any further investigations in this particular webinar, but it is very important that we must dig into the previous past records of the patient, because there are times when we are planning, let's say, for a case of a BOOP or a hypersensitivity pneumonitis. I may want to do a bronchoscopy with transbronchial lung biopsy, and if I ask the patient, he gives me some brand names out of his memory that he is taking, but unless I see the prescription, unless I see the list of the medication or the medications, I would not be comfortable doing a transbronchial lung biopsy, because he may be taking an aspirin or a clopidogrel, right? So taking a drug history is very, very, very important. And there are certain drugs that can cause the respiratory problems also. So we must look into this.
Thank you, Dr. Ashish. I think now we move on to the next question. This is to Professor Dr. Radha Munje. Ma'am, can you give your, by experience, can you tell us how would we do, how would be your clinical approach to a patient with chronic cough? And this is a very common problem which we see in our clinical practice. And how can we narrow down our differential diagnosis in such a patient on the basis of good history and clinical examination? Because most of the time what I've seen is a patient of chronic cough lands up in a huge battery of investigation, and which is actually not needed. So just to tell us, our audience, that how we can come down to a narrow diagnosis, narrow differential diagnosis and then proceed with only relevant investigation, which may be very minimal. So, to Radha, Munje.
Thank you for that question. And as we all know, and everybody who has joined the webinar, that cough is the commonest symptom of any case of respirology. The patients which come to you, the commonest symptom would be two, the cough and the breathlessness. So we need to, whenever we say that it's a chronic cough, we have to be sure that this cough has lasted for more than 8 weeks. So that is an important thing. Second thing, when you approach the complaint of cough in a particular patient, you have to determine what is the position of that cough today. Like, say for example, patient had started with cough 8 weeks ago, but what is the status today? लेकिन मुझे दिन भर खांसी नहीं आती है, रात को जब मैं सोता हूँ तब मुझे गले में कुछ अटके जैसा आता है और बहुत अनकंफर्टेबल कफ आता है. This can be one history, or there can be a history कि मुझे, then you have to dwell deeper into the other history of what has happened to this cough. And there may be few patients who tell you कि वो डॉक्टर साहब वो 4 हफ्ते पहले या 8 हफ्ते पहले मेरे बच्चे को बुखार आया था, फिर उसको सर्दी हुआ, फिर किसी और को सर्दी खांसी हुआ, फिर मुझे सर्दी खांसी हुआ, अब तो मेरे को कुछ नहीं हुआ, आई स्टार्टेड गोइंग टू वर्क, but I have a dry, hacky, troublesome cough. So then you can make out that probably what has caused the cough, like it was an infective episode which has caused a cough, but now the irritable cough may be only a post-infective sequelae with some irritation or a leftover inflammation in the throat, or we do not know whether it has resulted into a post-nasal drip because the symptoms were long-standing, or the patient already has some upper respiratory tract issues, or even has complaints or has developed sinusitis, or it was already pre-existing but he did not bother about it. Then we have to know that because the patient has had these symptoms, as Dr. Jain said, we should know what drugs the patient has taken. So is there any particular drug which the patient is already taking for his hypertension, which is resulting into this cough? Or is it because he has received loads and loads of drugs for cough to getting rid of this, and it's not getting rid because by this time patient has developed GRD which was non-existent. So it can be anything. So first and foremost, when you are talking about cough, I would always insist that you have to take a detailed history. Just for the sake of audience, let me add here that all of you are looking to your patients as consultants in your OPD, be it private, be it public. Many times it's not possible to give so much time to the patient. तो हम लोग ये एडवाइस करते हैं कि आप पेशेंट्स को थोड़ा सा वार्मिंग अप, जैसे नाम क्वेश्चंस आपने पूछ लिया, आप क्या करते हो, क्या होता है, by the time patient starts on his journey of symptoms or complaints, that is the time when you should start inspecting the patient and talk to the patient simultaneously. कई बार आपको एग्जामिनेशन में ऐसे फाइंडिंग्स मिल जाते हैं which you can correlate with the patient's symptoms, or it gives you a clue. उसके symptoms and the findings in the patient are either talking together in collaboration with each other and takes you to the diagnosis, or sometimes the symptoms do not match with the findings, but you know what you are looking at. So this is very important when you talk about chronic cough. And whenever there is a history of chronic cough, 3 things must be kept in mind. So 4 things I must say. One is it any post-infective previous trauma of infection which has left these symptoms of chronic cough? Are we dealing with somebody who has interstitial lung disease and hence presents with cough and less of breathlessness? Are we looking at asthma COPD? Or is this a bronchiectasis which is not infected but patient has continuous cough? So you should be from the history able to make out what type of cough the patient has. And then as we already teach many of our students, so I'm not going into the details कि cough के साथ expectoration क्या है, expectoration का quantity कितना है, quality कितना है, because it is assumed that all of you know about it and you are talking to it. So we are just thinking about chronic cough, and I think these 3-4 things must be kept in mind. And of course, apart from all this, any exposure to allergen, like person knows what is the cause of his cough, but somehow he is not coming out of that atmosphere where he should be avoiding these allergens for his cough, and still he wants to have something miraculous from his doctors. तो आप पेशेंट की जैसे हिस्ट्री लोगे तो वो पेशेंट खुद आपको कुछ ना कुछ बता रहा है. It is for us to listen. It's for us to extract and then correlate with whatever findings you have. Now, once you have talked about his symptoms, how it started, how it has progressed, what is decreasing the cough, what is relieving it, after that, at the same time, the clinical examination becomes very important, where you will never exclude looking at the upper respiratory tract. Many times that is the place where you should be looking for chronic cough. And of course, when you go on to auscultate the patient, you should be very keen to listen to the various sounds that comes from the patient, either in the form of adventitious sounds, like either there are crepitations or if there is a wheeze. That all should be heard, recorded, correlated, and then you would come to a diagnosis why this chronic cough is there and what is to be given. Here again is a word of caution. I have picked it up from Dr. Jain. Many times what happens, patient has chronic cough and patient receives cocktails of drugs. And इसी में ना बहुत बार expectorant होता है जो either the patient has not realized or even the doctor doesn't realize because it has a combination of few drugs. And this also gives rise to more cough. So you have to evaluate the patient first, know what is causing cough. And उसी के बाद आप सोचोगे कि हमको ये chronic cough को alleviate करने के लिए क्या देना. That's it.
Thank you, Dr. Radha. It was wonderful from your side. Just to add two things, any patient of chronic cough which comes to your clinic, there are two most common cause of chronic cough apart from asthma, COPD or other lung diseases is post-nasal drip and GRD. So
Yes.
don't forget to take a history like that. And if that's the cause, you don't need to do any investigation. You just go ahead and treat the patient, and then without you spending a single penny from the patient's pocket. So a good history and good examination makes a lot of sense. So yeah, I think I end this topic of chronic cough here. And then we move on to another symptom. This is a question to Dr. Nupur. Now, there has been a newer definition of fever. And I think we all have been knowing that fever we have been defining in a different way. It has changed, and probably it has changed the outlook of how we look at fever. And the fever which we used to call it fever in the past may not be fever anymore if you go by the current definition. So can you please elaborate on this? This is something interesting, something new. I feel that I should put it in our webinar. Yeah, please, Dr. Nupur.
Thank you, sir. So yeah, traditionally we have been defining fever as, it's nothing fixed, something more than 100. Then we say low grade fever is just 99 or 99.4. And the patient will, and then we usually ask the patient, did you have fever? They'll say, thoda sa bukhar tha, and maine goli liya, chala gaya. So what happens is there is no objective assessment of fever. I think that is lacking either from the patient side or even from our side. So there was a definition of fever which has changed now, and as per Harrison, so around a year back, fever now is defined as oral temperature which is more than 99.9 degree Fahrenheit or 37.7 degree centigrade. So why that happens is because they had conducted a study on a lot of healthy patients, and what they found is the 99th centile of temperature in all these patients was 99.9 degree Fahrenheit or 37.7 degrees. So that is why the definition of fever has changed now. In fact, in JAMA, maybe 2 or 3 months back, there was an article which was published saying that the average body temperature all around the world may be lower than 37.7 degrees, and it may be close to 36.6 degrees. And there were various reasons put forward for that, because saying that, the earlier studies which were conducted in patients who probably had some or the other underlying inflammation or some infection, but they never really manifested with fever or any symptoms at that time that the temperature was recorded. We have better antipyretics today, and that is probably why the average temperature also has lowered, but that needs to be validated in more studies. So as of today, the definition of fever is anything more than 99.9 degrees, and we have to keep in mind that this is the oral temperature, not the temperature which we check in the axilla, which normally is the thing which is done in the OPD or IPD. And another thing which I want to reiterate is that the definition of fever in ICU is different from the definition of fever which we check in a OPD or an IPD patient. So any patient in the ICU who has even a single elevated temperature, that is a temperature of more than 100.101 degree Fahrenheit, is considered to be fever in ICU. The definition for fever in a neutropenic patient in ICU is slightly different. So since neutropenic patients are immunocompromised, what we consider in them is a patient of neutropenia will be a patient with an absolute neutrophil count of less than 500. So in such patients who are in the ICU, if their temperature is more than 100.4 degrees Fahrenheit, but it has to be sustained for at least 1 hour. So in that case, that would be the definition of fever in them. But certain pointers we need to keep in mind is that critical patients who are immunocompromised, we will have to probably keep a little lower cutoff for them. So we cannot keep a cutoff of 101 in them. And secondly, many critical patients in the ICU either may be on steroids, or they may be on CRRT, or they may be on ECMO. So such patients usually tend to have a lower temperature. So we have to be cautious while defining fever in such patients. And patients who have a slightly elevated temperature in the ICU, they need not be always evaluated. So anyone with a temperature of say 100 or 100.2 need not be evaluated for the cause of fever. But if the temperature is 101, we need to investigate in the ICU. Of course, we have to keep the clinical background of the patient in mind as well, considering whether he's immunocompromised or not, and whether the patient is clinically or hemodynamically worsening. Then is the time we need to evaluate the patient.
Thank you, Dr. Nupur. It was really, you have given a very detailed description of fever. I'm getting fever now. So it was really wonderful how you described the whole thing. And now I think we should move on to Dr. Mahesh. Now, there is a question which I'm putting up to you. There is a known case of COPD coming to the ER with a short history of acute breathlessness and cough. What are the possible causes of this new onset of symptoms, and how can you clinically narrow down your DD? Because there will be a whole list of causes in this patient which is presenting to you, and in such patient, instead of going for a whole battery of investigation, probably a clinical approach may help you a lot. So, Dr. Mahesh, please.
Sir, it was a very wonderful question. First of all, I would like to thank CCI for giving me an opportunity and creating such a wonderful webinar topic that is very basic but very rare in today's clinical practice. So, sir, answering to your question, a patient is coming to emergency with an acute onset of breathlessness with cough. So, how clinically we are going to solve this issue? So whenever COPD patient comes with increased breathlessness, we must rule out minimum 3 to 4 things. First, we have to see whether patient has come in acute exacerbation. That could be an acute infective exacerbation. That may be viral or that may be bacterial. So patient may have cough with purulent sputum. Patient may have cough which is predominantly dry. May have some viral infections like upper respiratory tract infections, sore throat, malaise, myalgia, etc. And these kind of things we have seen more often during the COVID era. Then apart from this acute infective exacerbation, sometimes we have to see patients coming with acute onset breathlessness, which is in over hours, which is associated with sharp shooting chest pain. and patient is severely breathless. And when you examine the chest, and you see that patient is having asymmetric chest, one side movement is decreased, trachea shifted to opposite side, mediastinum shifted to opposite side, and on percussion you may get a resonant note, hyperresonant note. So this denotes that patient has developed probably a pneumothorax. So a bedside ultrasound or clinical suspicion, depending on the patient's vital parameters, you have to relieve the pneumothorax by needle thoracostomy or putting an ICD. Then sometimes the same patient with acute onset breathlessness, patient may or may not have cough, but patient may have a chest pain, and which is associated with sweating, and it's an exertional chest pain, and patient may have giddiness or other syncopal things. Then you may have to rule out the cardiac etiology. So a bedside ECG can give you can solve the issue. You may sometimes require cardiac enzymes or cardiology opinion. And sometimes the patients may present with breathlessness associated with hemoptysis. And when you examine the patient, you see that patient is having the asymmetric cough, and patient is having cough tenderness. So this suggests that patient might have developed the acute thromboembolism. And sometimes the severe chronic respiratory disease in the advanced stages may have a right heart failure. And in this case, the patient will present with breathlessness, with pedal patient may have a little bit of crepitations. And in such cases, when you do a 2D echo, you may see that patient may be having a dilated right heart or right ventricular hypertrophy. So this is an acute on chronic probable right heart failure. So 4 things we must rule out. One is the infective exacerbation, pneumothorax, cardiac etiology, pulmonary embolism, and right heart failure.
Thank you, Dr. Mahesh. It is really important for all of us to understand that whenever a patient of COPD comes to us with acute symptoms, it may not necessarily be an acute exacerbation of COPD. It can be pulmonary embolism, it can be cardiac cause, or it may be a pneumothorax. So don't forget them, because a lot of times you may miss a diagnosis if you're not careful about it. So I think that's really wonderful, Dr. Mahesh. Now we move on to Dr. Radha Munje. Ma'am, again a question to you. Are you there? Hello. Yeah, I think you. Hi. So now, how would you clinically approach a patient with chronic dyspnea? Again, a very important symptom in our clinical practice. So can you make a clinical diagnosis just on the basis of a good history and clinical examination, or you need to have a whole lot of battery of investigation? Again, you're a clinician, I want to listen from you.
No. As I earlier explained, for the chronic cough, one has to have a good approach to the symptoms of chronic breathlessness. What has really happened? I'll quote few small examples. So for example, you have a patient of pleural effusion has come to you. You have made a diagnosis, you have done a pleural tapping, whatever was possible, and the patient was put on appropriate treatment. Here we are not talking about what was the diagnosis. I'm just giving a tour of his symptoms of breathlessness, chronic breathlessness. And then what happens that the patient says that he was that time breathless. Then in between he was slightly better, but he was not well. And then he had breathlessness again, which is progressive slowly. So in this case, you have a scenario where you already know the diagnosis, and this breathlessness is because of the sequelae, that this patient is probably developing pleural fibrosis, which is limiting his lung movements, and hence he is developing symptoms of breathlessness. Whereas when we are talking there, at the other end, there may be a middle-aged male or a female beyond 50, 60 and complains of a gradual onset breathlessness, which is progressive. And at present, he is breathless on, say, walking on a surface for, say, 10 meters, 20 meters, and he is now alive. So this type of history, which has started in a later age, progressed very gradually, but now makes him very uncomfortable, is a classical history suggestive of interstitial lung disease. And more so, if you examine the patient properly, you look at him whether he has clubbing, you auscultate the patient, patient gets classical Velcro crepes, and you can really make a diagnosis of IPF sitting in your clinic. So you have a good history, you have taken and extracted what has happened, and then you have examined the patient as and come to the diagnosis. This is second scenario. The third scenario is, as we have discussed earlier, for chronic cough, it can be a case of asthma or COPD, which is either not diagnosed earlier and patient has been just going from one doctor to another for his complaints of breathlessness, or he has been diagnosed, he has been offered a proper treatment. However, the compliance to treatment is not there. That can be one thing, which is, that is why his breathlessness is not responding and maybe either gradually increasing, or the breathlessness is stable, or may sometimes have acute exacerbations and then it goes away. So everything depends on the history. And then when you examine the patient, you would find, if this is a case of COPD, you would definitely find all the findings of COPD in such patients. There can be pursed lip respiration, there can be prolonged expiration, there may be few accessory muscles of respiration which are active, visible, and have come in place. Then when you auscultate the patient, you may be able to auscultate these. Many times such patients, because they have breathlessness, so you really do not know unless you have examined and has completed the examination that what does the patient have. Now, there can be such patients can come to you when they have already received treatment for their COPD. They are better, but still the breathlessness is not responding. Why this is so? Because of this long-standing COPD, patient has by this time developed cor pulmonale. So if you, in this patient, sometimes the chest may be silent. However, just a moment, the battery is going away. Okay. Sorry for that technical glitch. Can you hear me?
Yes, please.
Yes. So, yes. So this can be really, patient has already developed cor pulmonale and is now developing congestive cardiac failure, and that is why, or say the right-sided failure, and that is why he has breathlessness. So there can be various scenarios where there can be breathlessness. Then there are cases of post-infective COPD, like a patient who had pneumonia earlier. However, though he has been treated properly, he has come out of acute phase. But after that episode, he definitely remembers that I was well for a small period. And then I started developing either cough or breathlessness. And now my breathlessness has increased. So you really do not know whether this is a post-infective sequelae that the patient has, or if a patient is treated case of tuberculosis, he may be having residual fibrosis or bronchiectasis. So there can be different scenarios. So first and foremost, as we started with the webinar, you have to take a proper history, including what diagnosis he has had or what type of treatment he has had. And at the same time, you examine the patient and then you come to a conclusion that what is the cause of this chronic breathlessness.
Thank you.
Anybody
That
wants
was
to
really.
add something which I did not touch upon?
I
Please
think
feel free to add, because our viewers should be benefited.
I think you have covered it very well. Anyone else want to put his comments on this particular symptom, the chronic breathlessness? Anyone want to add anything? I think that's wonderful. You have really elaborated it in a very beautiful manner. I think, yes, chronic breathlessness, we need just one important thing I would like to add is that, yes, we know that this mostly the patient coming to us may be coming with chronic respiratory illnesses, but there may be some other non-respiratory causes of chronic breathlessness. Don't forget them. The cardiac cause, the patient may be having anemia, or there may be other causes which need to look at. That what's the cause of his underlying condition.
Or
So
even
good
what
history.
Nupur gave in her, yes, and what Nupur Nupur gave in her example that it could be diabetic ketoacidosis and patient is not being treated properly, or a case of uremia who is complaining of breathlessness. Wherever there is either fluid retention and fluid overload, either because of systemic causes or because of cardiac causes, can also give rise to chronic breathlessness.
And ma'am,
So we need
I would like to add one more thing, that sometimes some of the patients, those who have a sedentary lifestyle, they are chronically deconditioned and they also can feel a breathlessness whenever they walk more than the usual they could.
Yes.
I think that's interesting. That's important. We need to keep all these things in mind before we proceed with any investigation. So again, wonderful from Dr. Radha Munje ma'am and Mahesh. You are really nice. You needed added this point as a comment. Now coming to Dr. Ashish Jain, I think there is an important question for you. Can you please, again, I'm going a little back on the history. Can you please give some examples of diseases which can be suspected by patients' demographic information? Again, that's something interesting which we should not forget. So please give your comments on this particular question.
Yeah, sure. The demographic information of the patient includes the name, age, gender, and their place of living, their geographical location. So there are certain diseases which one can keep them in mind. For example, if you talk about the age, there are certain diseases which you would see when the patients are more young. For example, asthma, allergy, they are usually, they present themselves when they are young, but later in the life, usually we see more of a COPD or ACOS, as we say them these days, in the older population. If we are talking about the ILDs, usually they are in the older age group. The cancer, the malignancies, they are usually in the older age group, although the pattern is, as we see, is little changing also these days. So this is regarding the age group. As far as the genders are concerned, the men are equal and the women's both are equal. But there are certain disease. For example, if you are thinking, or if you're seeing a case of ILD, interstitial lung disease, and if you're planning to, you're zeroing into the causes of the ILD, then LAM is one thing that will be more often seen that is exclusively seen in the females. One very important thing which I happen to see a couple of patients in last few years is of catamenial hemoptysis. That is one thing when you see a hemoptysis, recurrent hemoptysis in females, then this is the thing that should come in mind. Plus, you should be aware of what is happening in the surrounding. What kind of patient drainage area do you have? Are these patients coming from the slum dwelling area? There is a lot of sewage water in and around. What is the occupation of the patient? Should you be considering leptospirosis in these patients? Should you be considering just simple infective etiologies? The location of the patient also tells you that, okay, this is a overcrowded, low socioeconomic area. So the possibility of, or you would rank tuberculosis higher as compared to a non-infective thing is also, important. So these are the things that based on only on the demographic, once I receive the payment slip of the patient, and when I go through this, for example, certain race, certain castes, like, if you are looking at like, for example, sickle cell anemia, while I was practicing in Indore, so there was a large chunk of Sindhi population, those who would have these thalassemias and the sickle cell anemias. When I know that I am going to deal with a Sardar, I know that traditionally they don't smoke, so I should exclude the smoking-induced lung diseases and all. So these are the things we can infer, or we can at least prime ourselves when we are going to see a patient based on their only their demographic profile.
Any of the panelists would like to add anything to this?
Sir, I would like to add, sir. I would like to just give you one clinical scenario which I had encountered during my residency. A female, 75 years old. She was from a very well-to-do family. She presented with chronic breathlessness, and she was being treated symptomatically. When we did CT, we found out that she was having a bilateral emphysema. And then we asked all the changes which we saw on the CT are seen in the smokers. So then we asked, these are smoking related, but you are neither exposed to tobacco smoke nor exposed to wood smoke. Then how can it happen? So she said, yes, I do smoke bidis, because she was from the Rajasthan and they used to smoke bidis. So sometimes it happens, looking at a female that too from a very well-to-do family, we may feel little shy to ask the smoking history. Then she said that I asked, why did not you tell us about your smoking status? So she said, doctor, you never asked me. Otherwise, I would have said. So one must never forget to ask the relevant clinical history, just not keeping in mind that a certain set of people, certain religious people may not be doing this.
Yeah, no, I
Agree.
take your
So
point, Mahesh.
what can I add something here? So
Yes.
actually, what most of the consultants talk about is what was there in the textbook has already happened in reality. So we should not have a gender bias when you are asking any questions about either smoking or alcohol intake. Whenever it is related with a particular disease or gives you some clue, it has to be asked and recorded whether it is positive or negative, both ways.
Good. Yes. Yes.
Here,
Really.
here Dr. Sushil, if I can add, there is a significant change in the cultural scenario, in the social scenario in last 10, 15 years that we have seen. You know, initially I would be hesitant in asking the smoking and the alcohol history to my patients, especially the female patients. Right, and they would be hesitant and they would be shocked and surprised. Why are you asking me about my smoking history? But now the things have changed. Not only do I get more affirmative answers to this, but even if they are not smoking, they are not shocked about this. They would gently say, no, I don't smoke. As if they know that, okay, smoking is, the girls, they do smoke. So there is a
I
shift
think
in
we often
the
see,
scenario.
yes, we see very young smokers in our clinical practice. Females are smoking quite much. Alcohol intake has become very common. Agreed. I would like to add two more things in this particular demographic question. That is that there are certain areas which where certain types of parasitic infections may be common, like for example, Rajasthan or in Chhattisgarh, we see a lot of hydrated lung diseases. So hydrated cysts we see quite often. So I'm saying is demography plays an important role. A particular disease may be common in a particular area. So need to understand where is the patient coming from. A patient is coming from, for example, Shedol. They have a lot of coal mines there. The patient coming from there, I have to keep in mind that there may be a coal worker pneumonia. So I'm just giving you demography plays an important role. So we have to just keep in mind that where is the patient coming from, and maybe you may have a clinch to the diagnosis there. So that's interesting. I think anyone would like to add anything to this question, or we move forward?
Just stretching a little bit for that smoking thing is these days hookah is very common in young individuals, and they feel that this is just a part of it's quite an in thing and it's not a taboo in their family and in their society, so they don't even bother to tell you. There are young smokers those who start coughing, and then he would quietly tell you that, doc, I smoke 3 cigarettes a day, right? But hookah smoker will never tell you. They think that, oh, it's so cool, there's no problem, which is so so bad about it that we don't. So we must always ask about the hookah smoking, especially in the young individuals.
Yes, very
So
true.
once we were talking about these demographic, I must add that there are few areas where you have tropical pulmonary eosinophilia also very common. So history of
Yes, agreed.
passing worms, which usually a respiratory physician does not ask. So that should also be kept in mind, because now that in this webinar, we are not going to talk about anything beyond history and clinical examination. So
Agreed.
in this history and with history of chronic cough or breathlessness, and if you feel, then do ask about history of passing worms, and you may be able to make some diagnosis. Or in that, if they are coming from those endemic areas, there are certain endemic areas, like when we are in Nagpur earlier, we used to say that in areas around Chandrapur, you get many such cases and so on.
Great.
So,
In fact, ma'am,
I would like
actually,
to
there are quite a few patients, like in Goa, tropical pulmonary eosinophilia is not very common. But there are a lot of migrant workers who come themselves to me and they tell me they have been diagnosed with eosinophilia in the past. So
Yes.
the diagnosis is given to you on a platter. You need to actually go back and evaluate whether it was really eosinophilia. Is the patient asthmatic, or was the patient actually having tropical pulmonary eosinophilia?
In my place also, we see much more common eosinophilia. And a lot of patients have eosinophilia, and I diagnose almost one patient a month of topical pulmonary eosinophilia. So it's not so uncommon. So we have to see where the patient is coming from. That makes a lot of sense. I think now we move to the next question, the drug history. This is the question is to Dr. Nupur. What are the common drugs which you may be the cause or are the associated with respiratory diseases? Again, very important thing which we may forget and which may not be asking the patient and may miss a diagnosis. So, to Dr. Nupur, please elaborate on this.
Yes, sir. So, actually, a very important component of our history taking is the drug history. So, like Ashish sir had said, that we need to ask what drugs was the patient taking in the past, and what are the drugs he is on right now. So, very important is that the patient usually tells you the brand names. We need to actually dig and understand what are the actual medications the patient has been taking, and what are the conditions for which the medications were started. So that also might give us a clue as to what could be the underlying cause of the symptom that the patient has come to you with. So one important thing that Radha ma'am had said is chronic cough. So we need to find out whether the patient is on ACE inhibitors, or if the patient is on statins or angiotensin receptor blockers as well. So ACE inhibitors very commonly causes this chronic dry cough, and we tend to miss the patient's drug history, and we tend to evaluate the patient with a CT and various other investigations, and we usually don't come to a conclusion. So this is one of the symptom, cough, which can be induced because of a drug. The second very important is the presence of an underlying ILD. So patient coming to you with chronic cough and breathlessness, progressive breathlessness, patient becoming hypoxic, we tend to think of an underlying ILD. We sometimes miss the drug history, and we tend to evaluate the patient for a connective tissue disorder, etc. So there are various drugs which are implicated in causing ILD, but we need to remember that there is a lot of heterogeneity when it comes to the patient presenting with an ILD. So two patients may be on the same drug, but one patient will present with an ILD, the other may not. And two patients who present to you with an ILD who are on a particular drug, they may present with different ILDs. For example, patient may have an NSIP pattern, or the patient may present with something like an HP pattern. And the rate of progression of the disease will also vary in the patient, and sometimes there may not be a dose dependence relationship in this case. So that is what we need to keep in mind. The most common drugs which are implicated in ILD are the ones which are used for chemotherapy. So a very nasty drug, that is bleomycin, which is used for your germ cell tumors and all. So that is very notorious in causing ILD, and at times it has a very high mortality rate as well. And at times, initially it may be silent. So these patients need to be screened, and you need to tell your colleagues as well, who are probably in medical oncology or surgical onc, that if the patient is on this particular drug, you please evaluate the patient in terms of history. And in case you have any doubt, please send the patient to me, and you can actually help the patient a lot. Secondly, other drugs like your platinum based compounds, then there are your TKIs. In fact, TKIs are so commonly used for bronchogenic carcinoma. There are a lot of case reports of these TKIs also causing ILD. The other thing is antibiotics. So nitrofurantoin is one of the most common antibiotic which can cause ILD. The others are rare side effects like cephalosporins, and sometimes even there are case reports of AKT drugs which can cause ILD. The other aspect is amiodarone. So amiodarone is another very common drug which can cause ILD, and the presentation is very varying. Some of them can also cause pleural effusion. So nitrofurantoin, methotrexate, amiodarone can also cause pleural effusion. So at this, I think the dilemma exists in our practice of an undiagnosed pleural effusion. We don't know how to go forward. We have very borderline reports of an ADA, a neutrophilic or a lymphocyte predominant. We don't know how to go ahead, and at times we tend to start empirical AKT also for such patients. But just a simple history of probably a patient taking amiodarone or nitrofurantoin might actually clinch the diagnosis, and you can omit the drug and actually observe the patient. We may not even need to give AKT to this patient. Another aspect is patients developing pulmonary hypertension. So there are a lot of causes of pulmonary hypertension. We tend to rule out one by one, but we miss drugs at times. So dasatinib is one drug which may cause pulmonary hypertension. The classical drugs were the amphetamines, your suppressants, fenfluramine was very common in causing pulmonary hypertension in such patients. And last but not the least, there have been a few reports implicating ACE inhibitors in the causation of lung carcinoma. So there was a recent systematic review and meta-analysis which analyzed these studies, and they actually found a slightly increased risk of bronchogenic carcinoma in these patients. And in this case, there was a dose-response relationship. So patients who were on ACE inhibitors for a duration of say 10 years or more, there was a slightly increased risk of bronchogenic carcinoma.
Can I add something here?
Please, ma'am. We are waiting for you.
Yes.
Nupur has given an exhaustive list, but I would just like to add few basic drugs to which you should be looking at. One is aspirin or NSAIDs, which may induce asthma
Yes.
and
Great.
breathlessness in these patients. One.
Great.
And second is, as we have already discussed, that your history should be complete. So is there any history that the patient has gone to a physician or a cardiologist and he's not on any selective beta blockers, but is only on propranolol for one thing or the other, or even atenolol? And are these respiratory symptoms associated with these drugs? Because these are the commonest used drugs. And though people have a penchant for using newer drugs, there are still a generation or a class of doctors who would always stick to the basics. And we should always try to look at the history and whether these drugs are being prescribed and whether the patient symptoms are related to these drugs.
Yes, very agreed with you. This is really wonderful. Anyone would like to add anything to this?
So I would like to also
Can I
mention.
add?
Yes, sir, please go ahead.
Dr. Ashish, please.
Yeah, Nupur, thank you. As you rightly said, that there are a lot of chemotherapeutic agent that can lead to pulmonary fibrosis. So now in our hospital, in our department, we have made a principle, and I have discussed with various our medical oncology colleague. So what we do is we do a PFT with diffusion prior to starting these medications. Those selected group of medications, those who are known to cause the ILD, and we track them every 3 monthly or 6 monthly as the case may be. So there are a lot of patients in which we can pick them a little early and avoid the further damage, and then the drugs are stopped. So that is a very important thing that can help these patients.
Interesting. Yes, that's good. Dr. Nupur, you wanted to add anything more?
Yes, sir. Actually, one more thing. Many patients will come to you with a prescription, and there will be a lot of drugs written. But at times, we may miss the over-the-counter medications which the patient is taking. So you have to ask for a history of any intake of conventional or the Ayurvedic medicines. So that is also an important history which we sometimes miss, and the patient may not tell you because for him it is a very routine practice to just take an over-the-counter medicine. So he may not actually tell you that. We need to ask.
Sir, I would like to
Yeah,
add.
and
Okay, sir.
sorry, Mahesh, just 30 seconds. And I don't feel shy in Googling the brand names of the drugs which the patient brings, because the brands are very demographic specific, in some area, one brand is used and I'm not aware of it.
Yes,
So I
yes.
don't feel shy. I would just say, let me Google this for you. And I Google it and find out what is the
Good.
chemical composition.
Okay.
Mahesh,
Because we
please.
don't remember the brand names usually, so that's a tough thing. So yes, we have to check it. And I think anyone else want to add anything to this, or we move on to the next question?
I would like to mention about the few drugs, over-the-counter drugs available, one of which is NSAIDs. So one, we must ask about the NSAID abuse because they can cause gastritis in the form GID and chronic cough. They can have gastric ulcers. Plus this, again, pantoprazole or proton pump inhibitor, they are known to cause CKD. They are known to cause osteoporosis on the long run. There are some subset of patients, they have a gastritis and they over-the-counter go and take this drug like anything. There are some patients, they take at least 5 to 10 times in a month this kind of proton pump inhibitors. And apart from this, we have this notion that Ayurvedic medications, homeopathic medications do not have any side effect. So patients do not mention it. So we must ask about, as Dr. Nupur mentioned, about the Ayurvedic medications, because it may contain some of the heavy metals, plus as well as the homeopathic medications also as well. Some of the studies have shown that these things may cause on a long run some kind of nephrotoxicity or kidney issues.
And apart from this, if I can add, Dr. Sushil, to what Mahesh is saying regarding the Ayurvedic and the conventional medication, one is that the conventional medications that are available at the chemist shop, there are good brands also, Himalaya, Vedinath, and Jhandu, and other brands. So we know what the contents are. We can look up to, and there is very sketchy information available in the night, but still we can look up. My worry is from those doctors who give the churn and in the pudiya, and we deal with higher socio-economic group, and one would assume that people would not go to these doctors, but they go to these doctor and they dispense these churn and these tablets from their dispensaries, right? We don't even know what they are dealing with, and half of the time the kind of effect that the patient says is most likely because of the steroids. So probably it is the steroid tablet.
There are cases when there have been steroids in these so-called churn and purias, and there are cases when they found heavy metals in them. So these are the common things which are found in all these drugs. So important, we need to check them, and I think we should move on to the next question. We are like trying to hit. We are still stuck with the clinic history. Anyway, just one or two more questions on the history part. This is a question to Dr. Mahesh. Okay, now just because we have been discussing about ILDs and drugs causing ILDs, just another question on ILDs. There are certain ILDs which may be smoking associated. Can you just give a couple examples of which are the common smoking associated ILDs, which normally we associate smoking only to COPD, but there are ILDs also which may be associated with it. Can you please elaborate on it, Dr. Mahesh?
As we have less time, so I'll be a little short about the smokers related interstitial lung disease. There is a strong epidemiological association with interstitial lung disease with smoking in adult onset pulmonary Langerhans histiocytosis, in RBILD, in DIP, as well as in recently we used to think that acute eosinophilic ilia is related to smoking, but however nowadays last few years papers have mentioned there is strong association with smokers, with acute eosinophilic pneumonias. Apart from this, ILD related to smoking like IPF, even in some of like combined pulmonary fibrosis and emphysema, even RA-related ILDs have been seen more in smokers. Again, in pulmonary alveolar proteinosis also seen more in smokers. These are the certain forms of interstitial lung disease which are seen more in smokers.
Yeah, agreed. And I think this is like we have seen more and more cases of emphysema and ILD together, especially with when you go look at the CT smokers, when you get a CT scan done, you see there is an emphysema and ILD together, and probably we are looking at them more and more often. And that's why these patients are having both the components, and they have some response to even bronchodilators and ICS. So I think we need to keep in mind that all ILDs may not be pure ILDs, there may be combination of both the things, and that may change the management. And the question, Dr. Mahesh, if you have can you diagnose a patient with ILD and emphysema? How do you diagnose it clinically? Is it any way why you do that? How do you go about it?
So your voice.
Or there are any if you need.
Sir, your voice.
One second. Sorry. Can you listen to me?
Yes, sir.
Hello.
Yes.
Can you listen to me?
Yes, sir.
Okay, sorry for the connection. Now, what I'm saying is, we are seeing patients of ILD and emphysema commonly now. And how you diagnose these cases? Can we diagnose them on the basis of clinical assessment, or you need specific investigation only, or you can suspect and then investigate accordingly? How you go about ILD and emphysema together?
Okay, sir. Interstitial ILD and emphysema, that is typically known as a CPFE. Such scenarios are difficult to diagnose only on the basis of clinical, but they have very severe symptoms. They have fast progression of symptoms. They have very high smoking index, and they have very poor prognosis. When we do pulmonary function tests, they usually have the preserved lung function because of the emphysema-related emphysema-related increased lung volume and fibrosis-related low lung volume. So these two neutralize each other, and they have preserved lung function. However, they have a very low DLCO. Apart from this, they have low walk distance. They have more desaturations, and on a long run, they have poor prognosis and faster progression of the symptoms. As well as when we do a 2D echo, they have usually a disproportionate pulmonary hypertension. So this is about shortly about the CPFE.
Thank you, Dr. Mahesh. I think now we move on to another important question.
I think, Dr. Mahesh, we need to add few clinical signs which are very obvious in such patients. One, when we are talking about emphysema, pursed lip breathing is very, very common. And then you know that these are all, these are big puffers. So you have to be, you may see that these patients have, evidence of, their hemoglobin is raised, and there may be reddish discoloration of the tongue as well as the lips. And the way they sit and breathe, they are sitting on the bed, putting their hands on the bed, taking support when they want to take a breath. So these are the important things which point towards underlying emphysema. And then when you really are talking about ILDs, many things are evident. There can be the other systemic involvement which has led to this. So there can be external characteristics of, say, there is a rash, or the skin is rubbery, it is shiny, it has lost its blaze and cannot be pinched, and so on. So I think we need to emphasize on these points, which really gives us a diagnosis there itself. So you have reached a diagnosis. This is the time when you can tell your patient that probably your diagnosis is this. You have these symptoms, you have these findings, you have this. And whatever is the further advice of patient would only confirm whatever you have deducted clinically. But all in all, said and done, 99.9% you have already come to some conclusion in that particular patient.
You just have to confirm your diagnosis with the help of relevant investigation, a good quality lung function test, and maybe.
I would always say, like, you are in a place where there is nothing available. You are a doctor, like you are in a flight, you are going somewhere, you are traveling. Something happens, a patient comes with catastrophe, and then looking at the presentation and symptoms, asking a little bit of history, you may not have time. You should be able to come to diagnosis and offer something to the patient.
That's good. I think we move on to the next question. That's really wonderful from all the panelists. We are going very well till now. And now again, a question to Dr. Radha Munje, again coming to you. Hemoptysis, again a very important topic which we see in our clinical practice. And
Yes.
one thing important I need to ask you specifically, because quantification of hemoptysis is not looked very carefully by a lot of pulmonologists, and that may make a huge difference. And in your, I mean to say, in the management. So, can you just elaborate on how you quantify hemoptysis, and does it has any implication on the management of the patient, or any implication
Yes.
on the mortality or morbidity of the patient?
Yes, that is one of the good questions. As we all know, whenever patient has hemoptysis, and we assume that you have confirmed that he truly has a true hemoptysis and not a pseudo hemoptysis. It's very important to look at the quantification. Unfortunately, in respiratory medicine, we have not yet come across quantification looking at the volume of blood loss, because the blood is, flowing. There are many times there are not clots. I would just quote an example of a gynecologist. Say, for example, a gynecologist can make out that a fistful of clot is equivalent to so many ml of blood loss. That type of measure we do not have in our respirology. So any patient who loses about 150 ml of blood in 1 hour, or something beyond 600 ml in 24 hours, is a massive hemoptysis, and it's very, very alarming. And you need to give immediate attention to that. Now, when we are discussing the hemoptysis in this webinar, I would say that any patient who comes to you with history of hemoptysis, you have to observe the patient very carefully. And as it is, as we have said, and I would not repeat, that you have taken a good history, you have done a clinical examination, and then you have to know what is the underlying cause of hemoptysis. Do we have some clue? So, for example, there is a patient who has a history of cough. He has an history of copious expectoration. He has halitosis, and all of a sudden he starts having hemoptysis, which is alarming. You can be pretty sure that this is probably a case of bronchiectasis. Look for clubbing in these patients, and you may find it there. Now, if there is a patient who has only complaints of simple cough, he has had streaky hemoptysis, say, for past 2-3 months, and now he has sudden hemoptysis, and you have to examine clinically. Again, this patient has clubbing, but what he has something more is there is a lymph node in the neck. There is a history of smoking. So you are now very well dealing with a case of probably a malignancy, which usually patient would not have massive hemoptysis, but somehow this patient has had massive hemoptysis. Then there can be a patient who has other findings of, say, he has chronic cough, he has history of going to doctors off and on. And then if you are able to extract a history that he has been treated for tuberculosis, and this patient comes with hemoptysis, you know what has gone wrong there. Probably there has been a cavity there or a damaged lung, and those aneurysms have broken. He has either had secondary infections or a severe bout of cough, and now the patient has come up with massive hemoptysis. So one part of it is that you are trying. So most important thing is you look for quantification in your own way, try to stabilize the patient. At the same time, you look at what could have been the cause of hemoptysis so that the treatment can be given. And now you have examined the patient clinically. It's very important that if you can pinpoint which is the site, you may not be able to go which is the site, but which is the site affected. The first thing that you do is ask the patient to lie on the same side, so that you avoid patient aspirating his own blood and choking on himself. That is the first important thing which you should be doing. So it's important that whatever short time you have and what is the best of your capabilities, you examine and try to look at that. Then second important thing is the clinical parameters. Now, when the patient has come, there is a history, you have put your hand and you have taken a pulse. Now you have a thready pulse. It's a low volume pulse, or the BP is going low. You know that whatever he has brought out is probably less, and he's bleeding more inside his lungs. So that is important. And that is the point when you should be aware. That's the time when, apart from doing all clinical and critical care management in the emergency room itself, you must ask for a compatible blood and try to save your patient. That is one thing. Then pallor. Pallor को देखो, patient would become pale. Patient के eyes आपको sunken दिखेंगे. Face would also become pale, you know, like what do you say? एक अलग pallor आता है जब when there is acute blood loss, you know. And these are the things which you should be looking into. And then when you are auscultating the patient, examining, there's not only a thready pulse, but tachycardia. So each and every parameter lets you know how grievous this blood loss is. And it's important for us to assess this clinically. Because today we are discussing a scenario where you are not going to do or you do not have facilities to go beyond clinically. So these are all the things which indicates that how severely the patient has bled, and you need to stabilize the patient and take immediate critical care management for such patients. Few of such patients, I don't know whether they really do because I have not had personal experience, but few of these such patients may even need an acute surgical intervention also because the bleeding cannot be stopped by whatever means that you are doing.
Yes, we had couple of patients which every method failed and finally the patient died with hemoptysis. So we had every possible facility and we tried everything. Even we tried bronchial artery embolization, that also failed. Bronchoscopically, we tried to localize that one side. Still, we were not able. So there are occasional cases when we may have a trouble with hemoptysis. So quantification is an important aspect. And one thing, there was a study which I just wanted to. They have defined it as hemoptysis as mild, moderate, and severe. Less than 50 ml, up to 50 ml was mild. 50 to 200 was moderate, and more than 200 they said it was severe in 24 hours. And then they found that all the patients who had more than 200, those patients who had more than 200 ml of hemoptysis in last 24 hours, they had a mortality of as high as 20 to 25%. So that's important. Any significant amount of blood loss, say more than 200 ml, as per this study, has suggested that the mortality can be very high, as high as 20 to 25%. And massive hemoptysis, as Madam has rightly mentioned, an untreated massive hemoptysis can be having a mortality as high as 80 to 85%. So that's very important that you immediately admit the patient and go aggressive on treatment. So that's the important message to all the audience. Just before we move to another question,
Sushil, can I come in here? Since we are
right.
Sir, I would like to mention
one thing I should have added was that whenever you are taking history, asking relatives, examining the patient, please secure IV line first.
Yes, I agree. That's important. Yes, please.
Sir, there is no consensus about the definition of massive hemoptysis.
Agreed.
Literature has defined it differently. Some has mentioned 100 ml, some has 200 ml, some has 600 ml. But the practical definition of massive hemoptysis is any kind of hemoptysis which causes a hemodynamic instability is a massive hemoptysis, plus a hemoptysis which is 150 ml or more than 150 ml should be considered as a massive hemoptysis, because 150 ml amount of blood is required to fill up your dead space of your respiratory system. So if patient is not able to cough out the blood, patient will choke up in the blood which he is removing from the chest. So 150 ml and more than 150 ml clinically can be considered as a massive hemoptysis.
Agreed, there is no consensus, but at least I try to quote a study which has shown that, say, 150 or 200 ml, if you're having it, that much volume in 24 hours, be aggressive, go for bronchial artery embolization or the other method, whatever is available to you. Yeah, Dr. Ashish, I think you wanted to say something.
Yeah. So, since we are talking about the quantification, let me tell you one thing which I have made a practice in my clinical practice. And this is very important. One is on the first occasion when you see a patient of hemoptysis. Right now he's, let's say, bringing out 25 ml, 50 ml of the blood. But we must remember that, even if he keeps on coughing out blood, he will have, and if it is not kept in the mouth, then he will have enough time to at least go and seek a medical attention, and he'll have some time. But if he keeps even 50 or 100 ml of the blood in his mouth, which can clot in the mouth, and then he can lose his life. So even if he throws out about, let's say 750 ml of blood, that's okay. But if he keeps even 50 or 75 ml of the blood in the mouth, then it becomes difficult for the patient to survive, right? So there is a very important message that I every time without fail read out to the patient, that please do not look for a spittoon or a dustbin or a safe space to throw out the blood. In case, even if you are in the bed, make sure that you cough it out. Don't worry about the blanket and don't worry about the chadar and rajai. The second thing is that if he is in the lying down position, I always ask him to turn to the side, keep his head down, and continuously throw out the blood, right? Without looking for the surrounding. These things can be cleaned later if he is alive. But if he keeps these things in mouth, even for 50 seconds, 30 seconds, looking for some place to throw out the blood, then his life is in danger. If we have time, can I just share one anecdote with the audience, Dr. Sushil?
We are running out of time, but if it's small, you can just come
Yeah,
up with.
very quickly. So I was a first year medical resident in Ahmedabad. We have got a large ward with about 100 patients in one ward, and I saw one patient sitting over there on one side of the bed, and he cried from there, "Ki Sahib lohiya uche, I'm coughing out blood." So I asked my GDA or the peon to give him some spittoon, and then he decided to walk from that area to a bed near my desk where I was, doing all the paperwork. And I said, "Okay, okay, come here. We have got a suction facility on this bed. You come here, and you'll be close to me." He walked from behind me, and he lied down here, and I was doing my work. And asking him, "Abhi kaisa hai? Aur khun nikla kya?" And when I looked at him, he was a dead man. Right? This was the first mortality in front of my eyes while I had just recently joined, maybe 3-4 months in my residency, and I don't forget that scene. And this was really horrible, and I couldn't sleep for 3-4 days after that. So I've made it a point to tell all my patients of hemoptysis that don't keep your blood in your mouth, just throw it out.
That's really an important message to all the audience. Now I move on to the next question to Dr. Mahesh. Again, now we are moving on to examination part, because we have discussed a lot of history. There's still a lot of things left, but I think we can't continue with that. So we move on to the next question about the examination, general examination we are going for. And there is an important thing which we normally a lot of people miss, and that is the examination of the neck. Because I have seen that a lot of times you may miss things if you are not examining the neck. So Dr. Mahesh, can you elaborate on what should you look at when you are examining a patient of respiratory disease and you are looking at the neck? I would like to have your comments on that. Dr. Mahesh, please.
Sir, when we speak about the neck examination, the first thing everybody knows and comes to mind is the lymph node examination. So we must know how to do a lymph node examination. We must know what are the different stations of the lymph node examination. And just to mention about the lymph node examination, one must know what is the normal size of lymph node, what is the normal consistency, that is the softness of the lymph node, plus what is lymphadenopathy. So lymphadenopathy, everyone knows, is the size of the lymph node.
I'm interrupting you, Dr. Mahesh. I want you to have a broader view of the neck, just not the lymph node. Yes, you can proceed with the lymph node, but what are the important things you need to look at the neck? I remember my boss, Dr. Mahashur, he always used to tell, your respiratory examination is not complete unless you have examined the neck and the leg of the patient. That was his comment all the time. And I found I always check it, and a lot of times we have made a diagnosis just by looking at it. So I think you should give a broader view, and then specifically you can talk about the lymph nodes after that. Sorry to interrupt. Yeah.
So the first thing which in a neck examination we go for the lymph node. Second, sometimes we see that there's some signs of hyperinflation of COPD, like hollowing of supraclavicular fossa, then tracheal tube, thyromental distance. The thyromental distance is usually in cases of OSA patients. This is thyromental distance, is the distance between your this chin and this thyroid. This is less than 1.5 centimeter. So it means there is a higher amount of the subcutaneous tissue over there, and the higher chances that patient may have OSA component. as well as neck circumference is important when we see about the OSA, like 16 inches in female, 17 inches in male. And apart from this, the skin examination of the neck, like acanthosis nigricans, which gives you a clue related to insulin resistance. Then sometimes this acanthosis can be seen with some of the drugs like niacin, ocipils. Sometimes the pigmentation on the neck may be related to adrenal insufficiency. And like we say that in neck examination, sometimes we put a bell of the stetho on a trachea and we try to see what is the post-expiratory time. The expiratory time is more than 6 seconds, gives you a clue that this patient is having air trapping and his FU1 by FVC is less than 50%. As well as some clue related to heart failure we see by looking at the JVP. And we must not forget to see or just palpate the thyroid. Sometimes it may have occult malignancy, occult nodules in the thyroid as well. Apart from the lymph node, then we have to look at the lymphadenopathy. Then what is the consistency of lymph node? What is the size of the lymph node? Even a 0.5 centimeter hard supraclavicular lymph node can be metastasis from the lung or the stomach or GI tract.
Yes. Anyone would like to add anything to it?
And even, sir, in cases of pneumothorax, sometimes the subacute emphysema can be palpated in the neck.
Yes. That's important. Yeah.
So,
Ashish,
two more things actually.
Okay. Yeah, Dr. Nupur, please.
So, one thing is any patient coming to you with dry, irritating cough, with progressive dyspnea, especially in females, you have to look at the thyroid. There may be just an evident thyroid mass, which may be compressing the trachea, and that itself could be the cause of your symptoms. The second thing is a patient coming with stridor dyspnea. So sometimes if you just look at the neck, he may have an old mark of a tracheostomy tube. So that it may be a post-tracheostomy stridor itself. So that itself might tell you the diagnosis of the
Very good, Dr. Nupur. As far as the thyroid thing you said, I remember a patient who came to me. She was wearing, this is like about 10 years back. This is very important, interesting thing. This lady was wearing a salwar kurta and there was a dupatta. She was having it. So it's my practice to examine the neck all the time. So when I asked her to remove the dupatta and started examining it, and there was a huge thyroid there. And she said, "Doctor, I've seen 6 doctors before I came to you. You're the first guy who is removing my dupatta and examining my neck." And there was a large thyroid compressing the trachea. We got a CT done. It was almost 80% compression there, more than 80%. The patient immediately got admitted and got operated and was fine. She was labeled as asthmatic and she was on inhalers for a long time. No one examined the neck, and I got 6 doctors who she has met. 2 of them were pulmonologists, and no one asked to remove the dupatta and examine it. So that's interesting. And I always examine and make a point to do it, and that's what we should do it. And yes, post-tracheostomy stridor, again, important thing. We should look at the
one thing I have to add, when Dr. Mahesh explained so well about lymph nodes, we have to let our audience know that there are cases where you have just put your hand and lymph nodes are palpable. And then there are patients who have a palpable lymph nodes, but you have to dig into the neck to really see for it and make out that there is a lymph node, especially when you look for the Kalyani lymph nodes. And the most important thing, even if all of us knows, we must say that even if you have put 2 hands, use only 1 hand for palpation. You cannot use both the hands and compress the neck to look for lymph nodes for obvious reasons, because you don't want to put pressure on both the carotids at the same time. So I think these are small things which we must let our audience know. Even if they know it, it's a way of underlining its importance.
And just to complete the list, the front of the neck and the side of the neck, let's focus on the back of the neck.
Don't forget axilla.
Yes, definitely.
Sorry, Dr. Ashish.
And you may see a upper back hump, which may give you a hint about the chronic steroid overuse.
Yes.
That's interesting. Yes, that's good. So I think that's we completed the list of how and why we should examine the neck. I think another question is again, Dr. Ashish. what are the findings you're looking for doing clinical examination of hands and legs? What are the things we're especially looking for when you are examining the hands and the legs of the patient? And how can it can help you make a diagnosis just by simple examination or inspection of hands and legs? You're not even palpating there, just by simple inspection of the hands and legs. What are the things you look for and how it can help you make a diagnosis? Can you elaborate
Well,
on it?
one thing which we have already discussed in this webinar, and most of us know, first thing that I would want to see in the hands of the patient is to exclude the clubbing, right? Then the other things in the nails like koilonychia or any other nail abnormalities, the pallor we would like to see. The cyanosis is elicited in this. The signs, telltale signs of rheumatoid arthritis are seen in the hands, right? You can see the skin over the hand and find out whether the patient is having early signs of scleroderma or not. These are the important things, and obviously as we learn from our textbooks, telltale signs of chronic smokers where they'll have some burnt marks over the hand. I've never seen one, but I've read it multiple times. So these are the things that I would like to see. The chronic wasting of the muscles of the hand in the carpal tunnel syndrome or neuromuscular disorders, that will also help you sometimes in diagnosing certain things. Then if you go down to the legs, obviously you would like to see the edema, you would like to see the varicose veins, pitting, non-pitting edema, and do not forget to see the suppleness or to elicit any pain in the or tenderness in the calf muscles. That is also very important when we are talking about the pulmonology aspect. Lymphedema can be there in the legs. The hydration of the patient can be judged with the skin tone and texture of the hands as well as the legs. Unilateral hand edema, especially in a case of CA breast, takes you to the other diagnosis. So these are the things I would like to look for in the hands and the legs.
Anyone would like to add on to this, please? Any of the panelists, please? Dr. Mahesh? Yeah.
I would like to add, sir. One is about the Raynaud's phenomenon. We may have to ask the patient whether when she is exposed to cold, does it change the color of the skin? And one is the typically patients of scleroderma, they have very different kind of hard skin, tight skin, and they may have even the erosions of the digits also, terminal digits.
That's interesting.
Yeah,
I think.
Let me add one more thing to this. When examining the hand, I would also like to see the tremors, the fine tremors and the coarse tremors. And very important thing when I'm examining a patient of COPD is the flaps. They are very important. Clinical examination. I mean, ABG takes a lot of time, but the flaps can be elicited there at the bedside or in the OPD chamber.
Yes, that's. I think we have completed the list of things which you should look at. Anyone would like to add anything to the examination of hands and legs? I think we have completed the list of it. Now I move on to Dr. Nupur. There's another important question is for you. Importance of nasal and oral examination in your respiratory medicine practice. Again, I'm trying to come to those things which we normally don't talk. So I'm trying to come to these important aspect of it. So what would be how you would examine the nose and the oral examination, and what are the important things you look for?
So, in any patient actually who comes with respiratory symptoms, we should remember that the respiratory tract starts from the nose. So our examination also should ideally start from the nose, but in a busy practice, it's not possible. So for an example, a patient who has bronchial asthma, he may or may not be having an allergic rhinitis. So patients with allergic rhinitis, especially those who start out young, they have a faint line across the nose. It's called as an allergic salute. So that may be very apparent on an external examination itself. A patient of ILD, a young female coming to you with ILD, may just have a malar rash over her cheeks and her nose, and it may point towards an underlying SLE in the patient. Patient may have a very obvious DNS, which may be apparent even externally. Also, some patients may have a basal cell carcinoma or a growth over the nose, so that needs to be kept in mind. Patient may have a saddle nose deformity due to various causes in the septum, so that may be also apparent externally. So then you do an internal examination. So for that, sometimes you don't have the speculum, but then you just need to tilt the head of the patient a little backwards and lift the tip of the nose and just examine internally. Look for presence of a gross DNS. Look for any polyps or turbinate hypertrophy, which is common in patients of asthma. Patient who is probably having an underlying syphilis or is a cocaine abuser may have a septal perforation as well. So that is something which may be seen on an internal examination. We also need to look for patients, if the patient has any mucosal atrophy, patient having any mucosal ulceration. So this may be seen in patients of vaginous granulomatosis or patients who have underlying Churg-Strauss syndrome. So the nasal symptoms are very common in such patients. At the same time, when we look at the nose, we also need to examine the paranasal sinuses of such patients. So look for any frontal sinus tenderness, maxillary sinus tenderness also in patients, because they usually tend to have a rhinosinusitis. Then coming to the oral examination. So first and foremost, look at the lips of the patient. Is there any change in the pigmentation? Is there any cheilitis? Is there any evidence of a herpes labialis? So these may point towards an underlying immunodeficiency in the patient. Uh, Patients of scleroderma may have a fish mouth appearance. They have a restricted mouth opening. So that also is important. Once you examine the oral cavity from inside, look at the cheeks, look at the mucosa if it's healthy. Look at the tongue. Is the tongue dry? Is there any evidence of ulceration or any growth? Look at the undersurface of the tongue. Look at the openings of the salivary glands. Is there any evidence of infection there? Also, don't forget to look at the teeth. So when you look at the teeth, what we need to see is there any evidence of caries in the teeth? Is there gingivitis? Usually patients who have GERD, they tend to have a lot of enamel erosion. So that is a soft marker for patients who come to you with GERD. You also need to look at the tonsils, at the uvula, and at the posterior pharyngeal wall. So patients with enlarged tonsils or an enlarged uvula or an elongated uvula, it may be a cause in such patients for OSA. Look at the posterior pharyngeal wall. There may be markers of a postnasal drip as well. So, nasal and oral cavity examination is not just important for a routine practice, but even in patients of sleep apnea. So, that is usually where the examination starts. Again, ulcers in the mouth can happen, is one of the diagnostic criteria for patients of SLE as well.
Behcet
So, a lot
syndrome.
of systemic.
I think
Yes, sir?
Behcet syndrome would be added to it.
Behcet's, yes, Behcet's syndrome.
Anyone would like to add anything? I think you have been given.
I think we should even add looking for adenoids in children, because
Yes.
that is a commonest cause of cough, breathlessness, as well as snoring in children.
OS.
Yes,
So
yes,
we
that's
should
important.
keep our eyes open whenever
One
we come
more thing I
across.
would like to add, ma'am, is overall hygiene. So, in patients with poor hygiene, they are more likely to have lung abscess or aspiration pneumonia. So, patients of lung abscess, we do need to check the oral hygiene as well.
Yes, that's interesting, important. I think we have added very important topics. Good for the audience. Please remember these important small things which can make a difference in your practice, and you can be able to diagnose and manage this patient better.
Importantly, one thing, Dr. Nupur, and for everybody, something which we don't see often and hence we don't comment upon is the oral submucous fibrosis, which has become very, very common, especially in the areas that Dr. Sushil and me are there. People eat a lot of those addictive things called
Okay.
gutka and kharra, which is known
Yes.
to cause oral submucous fibrosis. And
Yes.
many times the mouth opening is as small as only allows one finger to go. I mean, I just cannot imagine what and how the patient eats, but we have seen such extreme cases and
And
we
the
must be
patient
aware
live
about
with like that, and they don't come for unless they are really in a bad shape. They come so late, and then you have to literally they have to go for surgery. And a lot of such patients pre-operatively they are called in for nasal intubation. We have to do it
it.
pre-operatively, and they are operating.
I mean, the pulmonologists have always talked about dental hygiene. We have always talked about the nose and the throat, but we have yet not talked about, oral submucous fibrosis.
I think that's important. Yes, that makes a lot of sense. Anyone would like to add anything, or we should move to the next question?
So in a respiratory case, who is taking an inhaled corticosteroid, we must check the throat and look at the oral candidiasis because most
As
of
it
them
is.
tend to miss it. And second thing, a suspected case of OSF, we must look at the Malampatti grading because that will give you an idea what may be the severity, and that may also be give you what kind of difficult intubation you may have if it's an acute critical care patient.
So yeah, in ICU, it is important that when you're doing it, just see what is the that's Malampatti grading is there. I think there we move on to the next question. Now this is to Dr. Ashish. Again, a very interesting clinical question. How can you clinically differentiate a consolidation from collapse? What are the telltale signs, or what are the clinical findings which will differentiate these two things? Dr. Ashish, please.
Yes. So, first of all, one must understand that we are talking about the clinical diagnosis of the consolidation versus collapse. So, what is the pre-existing, or what is the story leading to? The consolidation. In consolidation, the patient would come to you with cough, expectoration, high-grade fever, dirty color sputum, signs of sepsis, tachycardia, and fever and stuff like this. But in cases of collapse, you would have a patient coming to you with a sign of either aspiration or a chronic cough, some tumor obstructing the collapse, some tumor obstructing the bronchus leading to collapse. So this is the story, or the clinical symptoms with which the patient will approach you. That is when you're talking to the patient. On examination, obviously, you will get a lot of bronchial breathing, and you may get a louder sounds in cases of consolidation, while in cases of collapse you would tend it also depends upon what is the size of the. In cases of basal atelectasis, probably it will be very difficult for you to examine the patient, but in cases of, let's say, segmental or lobar collapses, you would hear a decreased breath sound. The tactile vocal fremitus will be reduced here in the collapse, while in the cases of consolidation, it will be increased, right? So these are the prominent things that one can differentiate between a collapse and a consolidation before we move on to the
It also helps. I think percussion, if is a complete collapse of one lung,
yes,
ICU,
yes,
ICU setting,
yeah.
you will call for like the ICU setting. This is your exercise, this is a pneumonia or a collapse. They're confused. So maybe a
Yeah.
clinical assessment may help. So
Exactly.
note on percussion, and then air entry is almost absent there. Here in consolidation, you get a bronchial breathing. So that's the few clinical signs which you need to look at, and then that may help you to diagnose and then move on to treat the patient accordingly. Anyone would like to add anything? Dr. Mahesh, you're trying to say something. Yeah, please.
Just to add on to Dr. Ashish Jain sir, what has mentioned, collapse and consolidation. So consolidation, you will not have signs of volume loss. However, in cases of collapse, you will have a signs of volume loss. Again, the collapse of two types: collapse with patent bronchus and collapse with obstructed bronchus. Collapse with patent bronchus will have bronchial breath sound. However, the collapse with obstructed bronchus will have a low breath sounds or absent breath sounds. Again, it also depends on whether this collapse is acute onset or chronic onset. If it's a chronic onset, it may have a chronic symptoms. However, the acute onset collapse that is mostly seen in ICU setup due to a mucus plugging or due to a unilateral or one lung ventilation or slippage of endotracheal tube, or sometimes due to a foreign body aspiration. So in such obstructed collapse, you will have signs of volume loss associated with low breath sounds or absent breath sounds.
Hello. Yeah. Now we have discussed about how to differentiate. I think we have covered most of the thing about consolidation and collapse. And yes, acute and chronic collapse may have a different clinical finding on examination. So that's important. Dr. Radha, anything you want to add, or madam? You want to add anything to this? Move on now.
No, I would not add much, but I would say that if there is a collapse and other things in the history point that you are suspecting either something in the bronchus or at the carina, then one should clinically be looking at the D spine sign, that is the bronchial breathing, which you hear below the fourth vertebra posteriorly, or just in the paravertebral region also sometimes at the same site. And this lets you know that probably this is a collapse secondary to something which is already there at the carina.
There is another interesting thing here. Yeah, please. Sorry, I interrupted you. Please tell me. Please continue.
These are the things, and of course, history of choking. We rarely ask this unless we suspect something. But whenever there are patients who have a very short history, but when your findings are consistent with collapse, then you must also ask for the forgotten history of choking, if any.
Yeah, for foreign bodies, I think that's important. So a young patient,
which indicates foreign body aspiration, no doubt.
Yeah.
So which lets you know what has actually happened.
Especially pediatric patient, it's important. I think they may not be.
Even for adults, many times adults also forget what has happened. And as Nupur was mentioning, you are looking at the oral cavity and there are loose dentures. Something like this can very well happen.
As foreign bodies come, yeah, we've seen dentures in the airways. So that's quite like not very common, but still we do see cases sometimes.
It's only the history, it's only the history which points to all these things.
And a localized monophonic wheeze, if you see a localized wheeze, only at that may be another important clue, especially in pediatric cases.
Which suggests either there was a foreign body or a growth. And even when we are talking about patients who have collapse or even pneumonias which beyond the obstruction sometimes, but I won't say about classical cases of pneumonia. Many of such patients give a typical history that like they are better when they are sitting, but when they lie down, they have more breathlessness, or vice versa, depending upon where the growth is, whether it is pedunculated and which part of the airways it occupies with different change in position.
Yes. Interesting. Yeah. So it may be positional symptoms. I think that's, it happens. Yes, I agreed with you. I think we move on to the next question. We have really passed our time, but I think we'll try to catch up with few of more questions. This question is for Dr. Nupur. Again, an important clinical sign is what is tidal percussion and how is this clinically important? I know it's a very simple question, but for I think for the PG students, it may be useful. It may be useful. So how you do it, tidal percussion, or what is its clinical importance?
Dr. So tidal percussion, yes. So tidal percussion classically is, it revolves around your liver dullness. So liver dullness, the upper border of the liver dullness, normally in individuals on the right side. So in the mid-clavicular line, it's in the fifth intercostal space. The mid-axillary, it's in the seventh. And in the scapular line, it's in the ninth. So that delineates the upper border of the liver dullness. So normally when you start percussing from the second intercostal space onwards, you get a resonant note if there is a normal lung. And by the time you're in the fifth intercostal space, there is a dull note, and that is attributed to the presence of the liver. Now, what happens in certain patients is that there may be the presence of either an effusion or an empyema. or the patient may be having a subdiaphragmatic collection, an abscess, or a enlarged liver, or a hepatomegaly. So in this, what happens is that the liver dullness usually shifts. Now we don't know why the liver dullness has shifted, and we are not going to go into any investigation. So we have to determine it clinically. So if there is a shifting in the dullness, this can be either due to a pleural effusion or it can be due to a subdiaphragmatic collection. So what we need to determine is whether the pathology is above the diaphragm or it's below the diaphragm. So what we do is we delineate the liver dullness, okay, and we'll find that it's probably shifted. Now what we ask the patient to do is take a deep breath and hold his breath. And then once he holds the breath, we need to start percussing again from that point on. So if there is a change in the note, that is, if the note becomes from dull to resonant, that means the pathology is below the diaphragm. Because the lung has moved, the diaphragm has moved, and the pathology, since it is below the diaphragm, that has moved. So the change in the note has happened because of that. If the pathology is above the diaphragm, so if the patient has an effusion or an empyema, there will be no change in the note after the patient takes a breath or a tidal breath. So that's why important is to do a tidal percussion when you are not sure as to where the pathology is. Of course, apart from your routine auscultation and abdominal examination as well, but this is also an important sign. So we may target our investigation towards probably an abdominal ultrasound, and we may find something there.
I think we are really going out of time. We have we are almost 10, more than 10 p.m. now. So I think before we end up, I just want to ask one important, interesting question. I think a lot of things we have not able to discuss because of shortage of time. But one important question to Dr. Radha Munje, I think because you have been a clinician, you have been in a government setup for so long. Can you please give us pre-operative fitness? Can give us a pre-operative fitness just on the basis of history and clinical examination? Can we give a pre-operative fitness like that, or you really need to have a documentation from the investigation? What's your take on it? That's something interesting, maybe controversial.
My answer would be yes and no at the same time, because in the webinar we are trying to enlighten people about good clinical practice also. And so in this era of CPA, I would insist that they would not commit. But then yes, for preoperative fitness, if patient already is like say unknown case of COPD and you are evaluating a person, or if there is a person who does not have a history of COPD but gives you a history of smoking, and then clinically you have examined and you find. Now, you are not going to do any investigation. So what next can you do is you can ask him to do a 6-minute walk test and just see what is his capacity to walk. Then there are other bedside tests like breath holding or single breath counting, and so on, or even blowing to the candle, which lets you know about the FET or his PFR also, for that matter. So these are small tests which you can do and which you can determine whether this patient can be safely taken for any surgery which is away from the thoracic cavity. Like अगर abdominal surgery होना है, spinal में कुछ होना है, and if these are the things and patients का single breath count अच्छा है, so you can, and you have auscultated a patient, there is no evidence of pulmonary hypertension, there is no hepatojugular reflux, so there is no evidence of cor pulmonale also, then you can safely say that yes, this patient can be taken for surgeries which are away from the thoracic cavity and which can be done either under the local or spinal or a regional block. That much I can always say. But whenever we talk about thoracic surgeries or surgeries which are to be done under GA, I would say that you can convince your patient that you are safe enough or you are not safe enough, but we would definitely need documented evidence. This does not hold true for emergency surgeries, of course, because that time these are surgical emergencies and you are in no way, can either halt or postpone the surgeries. But for routine surgeries, yes, I think basically you have to understand that for pre-operative fitness, whatever investigations that you advise are actually based on what history you get and what findings you get on examining the patient. So I think I have made my point clear. Surgeries beyond thorax, local, regional blocks, spinal fitness can be given if there is no previous history of known disorder, but only a clue like patient is a smoker, but single breath count is, is good enough, and there are no other clinical findings. Well, go ahead.
I think I agree with you, and I think especially thoracic and upper abdominal surgery, we have to be more careful.
Yes.
And patients who are with obstructive airway disease suspected or proven, we need to be more careful. Probably restrictive lung doesn't cause much of a problem. It's the obstructive one which can cause a problem. So symptomatic patient with proven or suspected obstructive airway disease, you have to be more careful, especially in thoracic and upper abdominal surgery. And to add on, maybe all the surgeries under general anesthesia for that sake. You need to have a documentation and stabilize or optimize the patient before sending the patient for surgery. That
Yes,
would be
yes.
my take.
Whenever the surgery is planned, you have to optimize.
Dr.
Yes,
Radha,
Mahesh
can
wants
I?
to-
Yeah, please.
Yes,
Please add.
yes, sir. Please go ahead. Please.
Can I add couple of points? Number one is we are also expected to ask about any allergies to any drugs, right?
Yes.
This
Yes.
is very important because and this can
Very,
play a
very
very
important.
pivotal role in the post-operative management. Second, Dr. Sushil, I always feel that the pre-operative fitness is a misnomer, and we are not, we can't make the patient fit. All that what we do is a risk stratification, right? Whether
Yes.
from the lung side, the patient can be, is mild, moderate, or severe, or what are the possible risks in the intraoperative as well as the post-operative period. Right now, once we have stratified the risk, it is between the surgeon and the patient to decide whether, and the anesthetist to decide
And the
whether the
anesthetist,
patient should
yes.
whether patient should go in for the surgery or not. So this pre-operative fitness is a misnomer. I think we are here to stratify the risk from the pulmonology side for a particular patient undergoing a particular surgery.
Absolutely.
My
Yes,
two
yes.
points.
But then we have to write it that way. They send a referral for pre-operative fitness, and especially I think even for transplant patient, they ask for a
Can't make
pre-operative fitness. So that's the.
Absolutely.
Sir, I would like to mention about what Ashish sir has rightly said, that it's a misnomer that everyone gives you a call for a fitness, but actually we go and we give the what is the post-operative risk of pulmonary complication. We can only give fitness when we are dealing with the patient who requires a lung resection or pneumonectomy. But this person is fit for the pneumonectomy or fit for resection or not. Second thing, some of the things what we do is if we are not having armamentarium of investigations like pulmonary function tests, spirometry, etc. So as Radha Munje madam has mentioned, 6-minute walk test, single breath count, something known as stair climb test also we can do, that can give us also a roughly idea about the fitness of the patient. And the fitness
Documentation would be important here. If whatever you're doing, document it so that it may be an evidence for all of us. No, so that otherwise it may be in trouble sometimes.
We get a reference for the patient is a known case of COPD being operated for cataract. Can you give fitness? So I straight away mentioned that surgery under local anesthesia does not require a post-operative pulmonary complication from pulmonologist. Again, sir, one thing, sometimes a person who is requiring a long surgery, some kind of malignancy or something, and they take a fitness 15-20 days back and patient is operated later after 15-20 days. So I clearly mentioned that the risk assessment should be done as per the patient's condition on the day of surgery after the assessment from a senior operating surgeon and senior anesthetist. If the operating surgeon and anesthetist are confident to give an anesthesia and operate the patient, we cannot hold the surgery. That we have to mention at that time.
Yes. Anyone would like to add anything?
We should keep our lawyer and attorney with us while we are examining the patient. Look at the kind of language that he is using. Fantastic. I really appreciate that.
Yes, I think now though we have not been able to cover every aspect of clinical pulmonology, but we tried to make the best of out of it, and we have been there for almost like more than 2 hours now. So I think we end up our session today. Thank you, everyone. Anyone would like to have the last comment for today's?
I would
Dr.
just say
Sushil,
that COVID epidemic has really taken away our clinical skills of history as well as examination, and the distance between the doctor and the patient has increased geometrically. However, the CCI webinars have brought many people together, as well as it has brought back the old scientific art of history taking and clinical examination in this webinar. So a big thank you, and all the viewers who are watching, I'm sure must have been convinced that almost everything in respirology, except for few things which we have not discussed, can really be diagnosed clinically almost perfectly.
I know we have not been able to cover every aspect of pulmonology because it's huge. So I tried to make it as clinically applicable, and those things which we normally don't discuss in a clinics. So I thought that would be interesting for the students and to learn those points which we are missing otherwise in your day-to-day clinical practice. I think thank you all the panelists for being here today. It was a wonderful session, and I believe I've tried to make it as simple and as useful to the audience. Thank you each of you, and I think we should close the session now. Thanks CCI, and thank you Dr. Krishna, Dr. Pradeep, Pradeep. Thank you all the administrative body of CCI. Thank you Vijay. Thank you each and every. Thank you Dr. Atri. I think I'm not being able to recollect all the names. Thank you, Dr. Ashish Dubey and other team members. And thank you, each of you, so that to making this webinar successful. And I think we end our session today. Hope that it was good for all the viewers, and we have tried to make it as clinical as possible. So I think we end our webinar here. Thank you.
thank you, Dr. Sushil. Wonderful moderation. And next time, I think we should expand it to a couple of more things like a pulse oximeter and an X-ray at least. So that will improve the.
But then in a very short time for preparation, I was able. Yesterday, last night, I sat for 6 hours to make this list of. I was from 7:30 to 1:30. I was just making how to make this webinar possible. Otherwise, it was hardly any time for us to make it And today, I think these days it's very busy. We are getting a lot of pneumonia, a lot of sick patients. So it's very difficult to get enough time. But fortunately, we were still able to make it, and within a period of I think 5 days.
I thoroughly enjoyed it.
Thank you. Thank you, Dr. Radha Munjal ma'am. Thank you, Mahesh. Thank you, Nupur. And we missed Dr. Tony. He's not there because of some family emergency. But I think hope that his son is fine. He had an accident at home. There was a blast of cooker at his home, and there was a problem. His son got some burns, but I think he's fine. I think we stop our webinar here and hope